Hi, we're here to talk on Sunday morning, and we got a little extra sleep, Alan, because they
Yep.
still have this daytime savings thing in. Although, for a future talk, I got one of these watches that tells you how much you sleep, because my son thought it would be interesting. And it said I only slept 2 hours last night. So I know I slept more than 2 hours. So if I fall asleep here, another talk is how all these devices now being sold to monitor you, so you can tell the doctor when you're sick, how accurate they are. So 2 hours last night, 4 hours the night before, according to this fine watch. But today we're going to talk in Return to Healing about pain. Alan, you're a pain doctor. My patients call me a pain in the neck very often. So there's pain in both of our practices. But honestly, as a geriatric doctor, I deal with chronic pain all the time. And also, the other thing about being a geriatric doctor is I see the most onerous consequences of pain medicines because this is the most vulnerable population. On the other hand, they're also vulnerable to pain, which destroys their body, destroys their lives. And, finding some balance between medicines and pain is really difficult. I mean, you deal with it all the time.
It's difficult, Andy, and it's most difficult in the geriatric population because, most elderly people we know their kidneys start to slow appropriately for their age, and they have diabetes and high blood pressure. And, what the world doesn't realize, everybody thinks we have a million pain medicines out there, and we don't. Essentially, we have opioid analgesics, we have non-opioids, which is Tylenol and NSAIDs like Motrin and Advil. And then we have other stuff that we throw in, like gabapentin and duloxetine, which are not pain medicines, but help some of the other symptoms related to pain. And the problem, especially in the geriatric population, is you live long enough, you are going to get degenerative arthritis of your knee, right, Andy, and your hips and your spine and your neck. And it's a painful condition. And, we've seen so many changes over the years of how to treat pain, and so many bad recommendations turn into worse recommendations. So, we did watch an overprescribing of opioids for simple things without the control associated with it. And then some bad things happened, quote, the opioid crisis. And then doctors were told by the CDC guidelines, don't write opioids anymore. And some heeded it because they were scared of their license, so they stopped writing opioids. And people who were taking opioids for the 20 years past had no choice because no new doctor would take someone on a high dose of opioid that wasn't theirs. And the pain management doctors stopped writing opioids when this came out as well, because they don't make their money doing that. They make money sticking needles in people's back. And what happened? Hence the opioid crisis. Doctors had to stop prescribing because of CDC guidelines. And where did people go? They had to get their drugs on the street. So yeah, this was created not by the doctors. This was created by the regulators.
And I lost a patient for this, a young guy, not geriatric. He had been on OxyContin, and he constantly quote unquote lost his drugs. There came a point where I just didn't want to prescribe it anymore. And I said, we got to start cutting it down. And we started doing it. He was in pain. He said, I can't live like this. I said, we got to try. And he went and got heroin and overdosed and died. Because, if we're not, if it, I didn't put him on the opioids, let's make that clear. But if we don't become their drug dealers, sometimes they will find another one who's not quite as ethical. That's one side of it. My grandmother died of a medicine called Flexeril, which was prescribed by her doctor for back pain. That's not an opioid. It's a spasm, muscle spasm medicine. From my reading, and Alan, you might have a different take. It doesn't work, other than to make you tired. And for my
That's
grandmother,
how it works.
yeah,
Makes you tired.
my grandmother became so tired she aspirated all her food into her lung, and that's how she died. She was 92. She had a good life, and she couldn't live with the back pain. Like you say, she had look these over-the-counter ones. Well, Tylenol gives you what does Tylenol give you? Autism
Makes you
now? I
autistic.
I always joke when I take some Tylenol. I say, God, I feel like I can't look in people's eyes anymore.
Mm.
Like Tylenol doesn't give you autism, but if you read the Johnson and Johnson book and other things, the overuse of Tylenol may be leading to more liver problems because when people take it when they drink, it's a problem. When people take too much of it, it's a problem. But I have found personally, when you prescribe it in a reasonable dose, it's safe and ineffective. So it doesn't work, but for people with bad pain. Then you have anti-inflammatories, which is what I took for my knee, Motrin, Naprosyn, Celebrex, you name it. And yeah, in older people, that's the number one cause of hospitalization from medicines are these drugs. I mean, they they could wipe out the kidney, but they could also cause major bleeds. So we got to be careful, especially if you're on blood thinners or aspirin or other things, which or if you have kidney problems that are teetering on abnormal. So yeah, I find ibuprofen works, but there's a limit. You take it for too long, you're going to run into problems. So Flexeril, ibuprofen, you mentioned gabapentin. I've seen some success with that. I've seen also it cause dizziness, falls, all the other stuff that this kind of drug causes. And then we're stuck with opioid. And Alan, you showed me recently an article on tramadol. Tramadol is marketed as this non-opioid opioid, but it is an opioid, and it's like fools everyone because doctors say, "Oh, I don't have to prescribe opioids. I'm going to prescribe tramadol, so now I'm safe from the regulators." But as you know, and this article shows, not so true.
Yeah, and I think that's what stimulated this review article that came out. So, just like, when OxyContin, that's the extended release oxycodone came out, they said it was a safer, effective alternative and didn't cause addiction. And it turned out to be probably the most addicting drug of all time because it was so potent. And, that company is now out of business and, every state has a lawsuit against them. But when Tramadol came out, it was marketed as a brand called Ultram, and Ultram was this non-opioid, as you say, Andy, which is a safer, effective alternative. And I remember the first time I read it, the first thing I noticed was interaction with SSRI, anti-anxiety, antidepressants, which we know are totally overused. And we know that, how many patients do you see that have pain or not depressed? So if you have pain, you're going to be depressed because we can't control your chronic pain. So hence they're on an SSRI anti-anxiety opioid. And together they cause something called serotonergic syndrome, which we don't need to go into the details, but it could kill you. And I said, wow, like this is dangerous. And I looked at the evidence back then, and the evidence when the drug was first released, obviously only a drug company study, was weak at best. And it really was never a good drug. I never started a patient on tramadol. I must admit, I have like 4 or 5 patients on tramadol that came to me on tramadol. They were fine. They refused to come off. They swear it works, including some that are on the SSRIs. So I continued it. But I never started a patient on it because I didn't believe the data from day one.
And like you say, there's a new study which reinforces that it's ineffective and potentially harmful and addictive. We always assume it's non-addictive, but it's addictive too. Anything that blocks the narcotic receptors in our body is going to be addictive because think about it. When you block all the narcotic receptors, you make more narcotic receptors, so you need more drug and to fill the new narcotic receptors, and that's the problem with opioids all along. Anything that blocks receptors, you're ultimately going to do that. And so Tylenol and Motrin don't do that. They don't block receptors, so you're not going to ever get addicted, or you're not going to get dependent on them. But these drugs, yeah, they all do the same thing. OxyContin blocks them for a long period of time, which made them even more addictive, which we should have known. I don't I didn't fall for the opioid salesman back then. That was like 30 years ago, 25, 30 years ago. Despite the fact that they came in and knew everything about me and my family and told me I'm the best father ever. Because they were looking at my daughter's statistics on newspapers and wow, what a wonderful dad I am. Do you want to sell some OxyContin? But and they knew how much I prescribed, by the way. So people blame doctors, and be, let's face the facts. Back then, the federal agencies that we are told we must trust told us that pain is the next vital sign. We had to draw smiley and frowny faces on our charts, and we had to control pain, or like in the nursing home, regulators would tell us that we're in trouble. So we started using narcotics. I mean, what the heck else can you do when nothing else works and you're now being told you have to control pain? We like you say, sometimes you have to live with the pain and figure out ways around it, figure out non-medicine ways to deal with pain. I mean, how do you deal with it when someone just is not getting relief and they're asking for more and more pain medicine?
So you can't cut people off of their drugs. You have to have, what I call a whole person, patient-centered, integrative approach. So you got to use multiple modalities. When patients tell me, you know, I don't want to do yoga, which probably has the best evidence for low back pain. I say, I can't do it. I can't get on the floor. I said, well, there's chair yoga. Everybody could sit in a chair, or you could even do it in bed if you're bedbound. Physical therapy, we know, manual medicines really work. And we know you have to use a combination of low dose drugs, not in toxic doses, to do the best you can. But the evidence is clear, physical mobility, physical activity, yoga, physical therapy, all of these modalities is really what's best. And that most of the drugs are just masking the symptoms. They're not treating anything underlying. And fixing the underlying is fixing the musculoskeletal structure underlying the problem that's causing. But again, it's like everything else. People in our country want an easy fix. Like, why should I work to make myself better if I could just take a drug? And I think that's the mentality here. But I think the big thing about, which struck me about the tramadol article is, one, the drug was released with very little evidence. This study was what's called, a systematic review, which looked at all of the randomized controlled trials on this drug, which, if I remember correctly, there was like 19 of them. And the analysis of all of these articles put together says the drug does not work. The benefit is minimal. The benefit was exaggerated in the studies, and that the risk of taking the drug far outweighs the benefits. And I knew this all along, and this is just another example because it's like this not just with these drugs, it's like this with so many of the drugs we use. And it's just another example of the medical industrial complex, especially big pharma, controlling what goes on, and that nobody cares that we're throwing medicine that's probably killing more people than helping them with their pain.
Yeah, and like you say, this seems to be the common theme of drugs. It's funny because one of the other things I do with patients when they have a lot of pain is I try to look if there are any drugs causing the pain, and we all know that there is a drug that causes tremendous pain in people, which is statin cholesterol medicine, especially as people get older. The two studies, because Alan and I we wrote a review article on the use of statins in the elderly. The two studies, which are never quoted and have never been replicated, show no benefit over age 80 and pain. It causes pain. So I'm always shocked when people are coming in pain and they're on these high dose statins and no one blinks an eye. It's, we got to do what we can do to help people. But I also think, like you say, there's this mentality, like we see with the obesity drugs, of look, we can't we've tried as hard as we can, and we can't try harder. We need a drug to fix us. And that mentality is a problem. I remember going to a lecture from a chiropractor 2 years ago on back pain, and his take was, look, since we've become a drug obsessed society, the amount of disabling back pain has gone up. It hasn't gone down. More people are
Exactly.
getting disability from back pain. More people now have back pain and want drugs for it than ever were before. His theory was people dealt with back pain. They accepted it. They lived with it. They, like you said, they found workaways around it. They did therapy. They did other things, and they expected to have pain because they have bad backs. So it was kind of like I have a bad back, but now you're not allowed to have a bad anything because there's a drug for it. And so what are we doing? We're hurting people, which is what his view was. We're creating a condition that's now making billions of dollars for the medical industrial complex by telling people we have fixes, whether it's the needles or the surgeries or the drugs. It's stuff that everyone leaps on because no one should have any pain. That's the first thing
Absolutely.
I'll tell you is we are human beings. If we live old enough, long enough, we're gonna have pain. It's just the way
Yeah.
it goes.
And when I get a patient on a statin in pain, the first thing I say is stop the drug for 2 weeks and let's see what happens. And like, oh, I'm gonna have a heart attack. Like people
Right.
literally think they stop it for 2 weeks, like they're gonna have a heart attack. It's like you're not gonna have a heart attack in 2 weeks. Like you're not gonna reverse the effects of this drug that you've been on. The only way we're gonna know is stop it. Stop it and see if your pain gets better. If it doesn't, well, it's not the drug. We got to look for another cause. But I'd like to shift for a second because this is also, I didn't think about it, and just it hit me when you were speaking about, our made up diseases. So there's another one that we could spend probably 5 talks on, fibromyalgia. I'm sure you've treated a lot of patients
Oh
with
God, yeah.
fibromyalgia in your career, and it's a controversial diagnosis, but one that didn't exist when I was a young doctor. We created it, someone came up with, I think 18 points or 20 points on your body. I forget how many points there are that, if you touch those points and someone's in pain, they have fibromyalgia. Like that is really definite science. There is no diagnostic test for it. There's no scan for it. There's no nothing. But if you touch these 18 areas of your body symmetrically and there's pain, they have fibromyalgia. And it's usually associated, you know, also known as perhaps, chronic fatigue syndrome or myalgic encephalopathy. Long COVID is being put into that category as well. And what happened there? Like, what were you treating? And many of these people ended up as opioid addicted patients, and it's on a disease that we created that didn't exist when we grew up.
And chronic pain in general is lumped under that fibromyalgia rubric when we don't have any strong evidence it's anything else. And honestly, I have tons of patients diagnosed with it, don't have tenderness over those points. It's just that they have some characteristics that are now part of the definition of fibromyalgia. And like you say, it's associated with chronic fatigue and irritable bowel syndrome, which, let's face it, Alan, are all manifestations of stress and poor
Absolutely.
sleep, which are the underlying causes of this. Rather than finding medicines to treat these pain slash sleep slash gastrointestinal issues, we need to go and figure out what's going on, right? What is the underlying root of this discomfort? But I think with a lot of pain, clearly, and you see this all the time, when people are stressed, their pain gets worse, all the time. And so dealing with anxiety in life, figuring out ways to do that and figuring out mindfulness and ways to cope with pain, to deal with it when it comes, to not be reactive and assume that when I have pain, I must take a pill. That connection we have to break. All that goes against what the pharmaceutical companies have been selling for a long time. And they might throw OxyContin under the bus, which they did, but I'm very cynical, as you know. I think they did that so they could preserve the other drugs and say, well, here, we got rid of the bad one, but we got tramadol still, so don't worry. We got you covered. And they're coming up with new ones. It's always the case.
Yeah, like OxyContin is just long-acting oxycodone, which everyone knows is Percocet, which is one of the most prescribed painkillers in the world.
Right. And look, we understand there's uses for these drugs, and I don't ever want to say there's not. I
Of
took
course.
ibuprofen for my knee surgery. They gave me a big bottle of oxycodone, which I didn't take. I was more concerned about my bowel movements than anything else. But they gave it to me in the hospital. It just didn't work. And of course, as a cynic, I didn't want it to work, and it didn't work. It's funny how the mind
Oh,
can influence how a drug works.
oh, that's real. So we know the placebo effect and nocebo effect. Like those things are real. Like
Right.
they're actually not jokes, and there's probably more evidence for the efficacy of those than there are for the drugs that we use most of the time. But Hey, we also wrote an article on this. Me and Andy wrote an article on the appropriate use of opioids, like that appropriate people need them. I have dozens and dozens of little old folks out there with degenerative arthritis of their spine, hips, and knees that, you know, don't need surgery, don't want surgery, but in order for them to, they can't tolerate NSAIDs, maybe because they have an ulcer and they're taking aspirin and, other blood thinners, and the 2 grams of Tylenol that's recommended in elderly people doesn't do anything for them. Well, what do you have left, And I have tons of people that I give like, 100 Percocet or 100 Vicodin, which is hydrocodone, a very similar drug, that literally go through it in like 3 months. Like they take one pill every few days so they could get to the supermarket, so they could go to their family functions. They've never taken more in the many years I've taken care of them. They've never developed an addiction because the only way you're going to take an addiction is if you keep taking these things. I tell people, take it once in a while to get to the event that you need and you'll be fine. And the people who use them appropriately, like I said, I never made a little old lady or a little old man addicted to these medications. And without it, and when we wrote the article that there's some appropriate patients, like we got editorials and emails and letters that, essentially said we were not real doctors. We get a lot of those when we write our articles, either that we want to kill people by not screening them or that, we're not real doctors. We don't know how to prescribe. Oh, I remember the letter. It says we don't practice evidence-based medicine. And I wrote an editorial back. I said your editorial was not evidence-based, and luckily they published it on us because his editorial was just his personal opinion and not based on any evidence or any fact.
Remind me, his editorial was against using any opioids, right?
Nobody should be on an opioid.
Yeah,
No one.
and yeah, we of course I use them too. I find if you use low doses in elderly people, um, some people have severe side effects, can't use them. Some people, their lives come back to some extent. They're
Yeah.
able to do things they couldn't do before. And again, the studies are pretty, they're not many, but the one study that was done showed that especially in elderly people who have no addictive history, 1 in 2,000 get addicted to these drugs, and that is probably based on a bad prescriber who gives too high a dose to use every day. Which, like you say, we don't do that. We use them periodically, and they're great. In fact, they're in some ways when used like that, they're safer than Motrin drugs, non-steroidals. They are not the number one cause of hospitalization like those, and they're more effective than Tylenol. But yeah, well, it's just a matter of finding a balance between these medicines. But again, using non-pharmaceutical modalities as much as possible, movement, and using the idea that you're going to have some pain. We're not getting rid of pain. We're mitigating, we're reducing, we're making the pain so that you can function. That's all we're trying to do. If we go too far, then now the drug is your problem and not the pain.
Well, we know many times, as Osler said, when you prescribe something for a problem, now you have two problems, the
Right. And
problem and the drug. And we just that is such a classic example before polypharmacy became so prevalent as it is now. Like it's more applicable today than it was, over 100 years ago.
yeah, back then they used just a few drugs and then some leeches, It's a
Yeah.
different problem. But now, yeah, we are loading on so many drugs that they interact with each other and they accentuate each other. They one drug causes the other one to cause more side effects, and no one knows what's going on. So the doctors send them to specialists to deal with the side effects of drugs as though they're new medical problems. And they start more drugs. We see this, and so we're kind of protect with the opioids. I think pain doctors deal with this, but it's really in the primary care realm. I mean,
Oh,
we deal with opioids, and I think it's something I'm happy to deal with because I do. I'm not a like you. I'm not an absolutist. I use them. I use them in low dose, and I found good success with them if used appropriately.
yeah.
And it's not a binary. It's not good or bad, and that's what we have to realize. Low doses of several drugs can help pain more than anything else. from the
Absolutely.
pharmaceutical standpoint. I also use turmeric personally, so that's another way to.
Probably equal evidence to tramadol. But
Yes,
but if
exactly.
you look now, the pain docs, the least evidence-based field that we probably have in medicine now, because they all cut all their patients off of opioids. They probably were the biggest culprit in the opioid epidemic. And they went to everybody getting, three epidurals and nerve stimulators and vertebroplasty and all these useless things. We could talk about that British Medical Journal article that says no one with pain more than 3 months should get any of these procedures, that there's no evidence that they cause more harm than good. But we're spending billions of dollars in this country on interventional pain procedures that do not work. And when I tell patients this, they're like, no, no, I had my 3 shots. I feel fine. And I said, yeah, you're going every 6 months for 3 shots. And now you have diabetes and osteoporosis and all the side effects associated with it. And I could give you a steroid pack for 5 days. It's going to do the same thing. And we're just giving you steroids.
Yeah, and then I use that all the time too. I just give them a burst of steroids. That often people say, but those are dangerous. I said,
Getting
yeah, if you take them for months, yeah, I get it. There's a problem, but we're not doing that. They're the best drug ever, short term. They fix all sorts of stuff. Um, and they're certainly better than what you're planning to do with yourself. So, yeah, I think when we treat pain as a whole patient problem, deal with underlying causes, deal with non-drug ways to deal with it, and use drugs appropriately, which are different for every patient, like we talked about. So, my grandmother should never have been put on Flexeril, and a lot of people should not be put on anti-inflammatories. We have to use them appropriately, and
Absolutely.
and I think that's what we do. We're good at that in primary care because we understand the whole body, and we're not sending people to specialists for the side effects of drugs. We understand their side effects of drugs. We're always on the lookout for the side effects of drugs. So that's where our radar is. Okay, any last thoughts, Alan?
It's a big problem. This shows many problems with our healthcare system, again, being overrun and led by the medical industrial complex, that we do so many things with no evidence, and a lot of times, maybe more often, by prescribing things, we hurt people more than we help them. So, more is not necessarily better. Less is often better. So, I think that needs to be the philosophy. And, you have to have a holistic approach. You got to use non-pharmacologic modalities.
And again, my last word is you can't always rely on the medical system to fix all your problems. I mean, a lot of it is in your own hands, and you're going to have problems as you get older, and some of them you have to accept. Unfortunately, we could help. We could help, but we're not going to get rid of it. If we're going to get rid of it, we're going to get rid of it at your expense. Unfortunately, other bad things are going to happen, like with my grandmother and a lot of other people I've seen, where yeah, they're not in pain now because they just died. So, I mean, that's the problem. Okay, Alan, well, have a good Sunday.
All right, you take care.
Okay,
Bye-bye.
take care. Bye.